Welcome to the January 2023 AIAMC webinar in support of our National Initiative 8 on JEDI, Justice, Equity, Diversity, and Inclusion. Today's presentation on sustainability will provide you with valuable tools to ensure that your National Initiative 8 projects don't end when our initiative ends in late March, but rather your project will be the foundation for hardwiring your important JEDI work into your institution's culture. Before I introduce our speakers today and the presentation formally begins, I do ask that you please turn off your cameras and mute your audio and/or phone lines so that we can clearly hear and see our speakers today without distraction. If you wish to ask a question at the end of their presentations, please feel free to turn on your audio and/or video at that time. And also don't forget we have the chat box. It's a great tool to type in your questions or comments at any time during the presentation. Finally, your feedback is really important to us. At the end of the slide deck, we'll have a QR code for a very brief evaluation survey. You can let us know how we did today. We'll also have instructions on how to apply and receive CME credit for this webinar today. And we note, even if you're watching the recording, you may indeed get the CME credit. So it's my honor and privilege now to introduce our speakers today. We're going to start with Dr. Emily Fisher, who is teaching faculty with the Napa Solano Family Medicine Residency and also medical director for One Love Vallejo Mobile Health. Emily also served as team leader for National Initiative 7. Joining her today will be Dr. Victor Kolade, who is core faculty of the Internal Medicine Residency at Guthrie Robert Packer Hospital, as well as clinical professor of medicine and regional clerkship director for internal medicine at Geisinger Commonwealth School of Medicine. Victor has served as team leader and/or member in our national initiative since National Initiative 5. Emily's going to kick us off, but both Emily and Victor, welcome and thank you so much.
Thank you very much. So I'm going to go ahead and share my screen. Okay, is everybody seeing? We're good? I'll take the silence as a yes. Thank you. So hello, everyone. Thanks so much for having me back. It feels like a very long time since my AIAMC National Initiative 7. But Deb, it's nice to see your name at least. Deb ran our cohort meetings during my national initiative. So I have come back just to talk with you guys about what our project was during National Initiative 7 and then what we've been doing since. So our cohort was kind of focusing on clinical and quality outcomes. So first, I've got for you essentially what was our final presentation at the final meeting for National Initiative 7, and then we'll move on into what we're doing now. So our project was really a kind of residency nonprofit partnership. As was mentioned, I am both faculty at the residency program, and then I also run a street outreach team, which is part of the nonprofit Fourth Second. And so the residency and the nonprofit kind of partnered up for this project, focusing on street outreach to Team for an End to Homelessness. My national initiative was focused very much on interdisciplinary teaming. So we, as a team, are focused on, reducing the burden of disease and improving wellness of people without homes. And for the National Initiative 7, we were specifically focused on expanding our service provision so that we were really able to facilitate all the supportive services that had been identified by our target population as high needs that for a lot of people, they ranked higher even than medical need. And so we wanted to really develop a more robust referral system and follow-up system so that we could make sure we were utilizing our entire team to provide all the integrated care that people needed. Now, I have the fun distinction of having been part of National Initiative right before COVID happened, and then the majority of National Initiative 7 was post-COVID or during COVID. So our pre-COVID plan was this integration of referrals. However, once March of 2020 hit, much of the street outreach work ended. That was primarily because at the time, we were really dependent on other service providers to kind of bring us to curbside communities, as well as provide transportation for people to come see us at outreach events. And many of like this picture, for example, is at one of the curbside communities that we would set up at. But once COVID happened, many people were very concerned about safety. We were very volunteer based, really required medical student volunteers. They were no longer allowed to come out with us. So the theme of that year was pivot. I think that word was used about 25 times a day. And so we had to come up with a post-COVID plan. And so because of kind of the systems that we had been able to set up, we were able to jump on an opportunity. Here in California, we had a program called Project Room Key, which I think was done in different ways in other states and countries as well, in which medically vulnerable people experiencing homelessness were housed in hotels to try to prevent the spread of COVID and try to prevent those people from developing severe complications from COVID. So here in Vallejo, our team was able to meet and work with the city and another organization called One Love Center for Health to ultimately go on site to this hotel where roughly 120 people were housed during the COVID pandemic. And we were able to create essentially from scratch a medical service 3 days a week during the almost 2 years that Project Room Key was in place. So our new goals here really were to try to bring some of those goals from the street outreach space and utilize some of that framework for now this new setting. So over the next year, what were we able to accomplish? The graphs that you're seeing in the middle, these are really just some of the baseline demographics of the people that we were caring for. Some of this included kind of pre-Project Room Key, some of this included post. So as you can see, the majority of people we were caring for were over the age of 50. Most were insured, though the majority could not name a primary care doctor, which is a pretty common theme that a lot more people have technically access to care, but aren't necessarily utilizing it. The majority of the people that we were seeing were men. So pre-COVID, we were able to complete an asset mapping of Vallejo and created an easy to use referral guide that we called all the organizations in the community. We updated phone numbers. We understood what their referral processes were. We created a whole new referral workflow to be used at our outreach events. That piece kind of got put on hold. And then once we moved into the Project Room Key space, that really ramped up our ability to form partnerships with these organizations that we were trying to refer to, because on site we had the county public health, we had case management, we had the city of Vallejo. And so we really leveled up in our ability to do these referrals and to have these kind of interagency relationships. During this time, this is also when VMH was able to really partner with One Love Center for Health. And they have a partnership with the local nursing school. And so we're able to bring in even more interdisciplinary work. We ended up having Masters of Nursing students and NP students who were able to do clinical rotation hours with us. And again, kind of following the steps as they became available, as people moved into other transitional housing locations, we were able to then apply some of the model from PRK to other locations. So again, a little more of the kind of initial demographics of our patient population. The majority of the people we were seeing had been without stable housing for at least 1 to 2 years. But the next biggest chunk are those people who had been without stable housing for at least 10 years. And the majority of the patients there were unemployed. So then looking at the actual care that we were providing, the majority of the visits were for acute care, though we always tried to have a lens around chronic disease management with a plan to be bridging care to primary care doctors. And so we were always trying to figure out, where is this patient supposed to be seen on a regular basis? And we would often reach out to, who their primary care doctor was of record, or who their clinic was of record, even if they had never been there, so that we could ensure that they had kind of long-term sustainable care. And then looking just at our visits, this May to June graph, that's right when PRK started. So we did his H&Ps for every single person as they entered in. And then we were available, like I said, 3 days a week. Interestingly, and this is a pattern that we'll see kind of in the later project, when we didn't have a case management team on place and didn't have any kind of other administrative presence on site, the usage of our services dropped really dramatically. But then as those kind of supportive partners came back online, you see those visits increase. So these are just some of the questions that they had us answer in the kind of final project. I think some of the challenges that we found, and what was most surprising, is how difficult gathering data was, especially since our project changed pretty dramatically after we had created all of these lovely plans for how we were going to be collecting this beautiful data. Then suddenly we were in a worldwide pandemic with trying to coordinate volunteers that were disappearing, trying to coordinate, across a different provider every single day to try to get consistent data. And then much of the data, so trying to track referrals, for example, there are different systems that our case managers use, different systems that our medical team was using. And so trying to get everybody to swim in the same direction was definitely challenging. We also found that a roof doesn't necessarily always equal better health for our patients. During the Project Room Key period, we started out at a pretty nice hotel at a Hampton, and then funding got smaller and we moved to a much less nice hotel that ended up having some pretty significant mold problems. And many of our patients who had respiratory illness, which was a lot of them, ended up getting much worse. We saw a lot more COPD exacerbations than they had even been having when they were living outside. And so the importance of not just a roof, but a good quality roof actually does make a big difference. And I think a big surprise for me, just as someone who came very much from the MDDO world, I really hadn't done that much work with nurse practitioner students or even like PA students. But because of the partnership with One Lab Center for Health and this woman right in front, she's the one who's in charge of that organization. We ultimately, the nurse practitioner students ended up being life-saving for us because they became our most consistent source of support. So what would we have done differently next time? So like I said, establish the data plans from the very beginning with all of the different providers so that we had a central system and collecting things as we were going. We ended up doing a lot of backtracking to try to gather data after the fact, which is just so much harder. And then developing a method to create a more accountable kind of volunteer base from the beginning. Like I said, that became much better once we were able to set up a clinical rotation with the NP students. And then a big piece, especially for this population, was the ability to communicate with providers at those kind of home clinics. Since, we as a street outreach team really don't have the capacity to act as primary care doctors for this population, it's really important that we're able to do these warm handoffs, but it was far more difficult than I would have anticipated to connect people to, one, find where people were supposed to be seen as their medical home, and then actually get them connected to doctors. We would see patients in their hotel rooms and we see these wounds, or we see how we are measuring their blood sugars and their blood pressures, and sometimes getting that information, and then they'd go to an emergency room and nobody there would know what we had been doing, and they would get discharged with a plan, but then that plan wouldn't follow through. And so finding a way to kind of fix these lines of communication is an ongoing plan, but certainly would have made some of that work easier. So our most important piece of advice are our keys to success, having really defined roles within your team from the beginning, so that you don't end up with just one very passionate person doing a lot of the work. With that said, having a very passionate person at the lead is really important, because a lot of this, like I said, pivot, we had to keep changing. And if you didn't have kind of that leadership structure that knew that this was the right work to do, it's hard to kind of keep moving, as it can sometimes just feel like you're trudging. And then again, clear communication, despite being in separate spaces, a lot of the people we're working with, we ended up being completely virtual, as we all kind of learned that lesson in 2020. And then just really the importance of being able to team across the different service providers. So not just our medical team, but also with the case managers, the other service providers that we're able to work with. So what happened next? So that basically was the end of our National Initiative 7, which over a year ago now. So shortly after that, the Project Room Key project ended. It closed actually a year ago, as of like 3 days ago. It closed January 4th, 2022. At that time, there were still about 35 people who were living in the hotel, who were going to be sent to the street. But we were able to coordinate with the case management team we had been working with in the city of Vallejo to get funding to essentially do a 3-month transitional housing program for those patients. And then the majority of those people we did find housing for. And we continued kind of the PRK model where we were providing care at the transitional housing as needed. And then a big kind of longitudinal sustainability piece of this is that One Love Center for Health and Vallejo Mobile Health kind of officially joined forces as now One Love Vallejo Mobile Health. And we were able to reinstate street outreach work as of July of 2021. And so we now are able to provide a once monthly multi-service event, and then we go out and do street outreach once a week as well. And we continue to really rely on our learners. We work with the family medicine residents, we work with the Toro medical students, the nursing students, and the PA and sometimes a pharmacy student joins as well. So looking again at kind of how the project has kind of morphed and how we've taken some of the lessons learned. This is just looking back again at some of those lessons that I mentioned, or things that we would have maybe done differently. And like I mentioned, one of them was developing a method to create accountability and consistency. So like I mentioned, having kind of the clinical rotation with the NPs was very important, but we also recognized that this type of care, a lot of our students, we're very hungry for, but also would point out that it does require a certain specialized skill set. And the quality of the care we're able to provide really tended to vary based on kind of the previous experience our students had working with this population. So we actually worked with 3 of our medical student volunteers to create an interprofessional elective in street medicine at Toro University. We were able to give the first session of that last year. We're ramping up to do the next round in the next couple of weeks. And it's a semester-long course, and talking about, not only medical issues that we see with this population and how to care care for that in the unique street space, but also just a little more background into homelessness in this area and why are people homeless, and trying to help people maybe recognize and counteract some of the biases they might carry into working with this population. And a key component of this too is there's a requirement for volunteer hours that's part of this elective. And so it has guaranteed a consistent volunteer pool. And then out of this group, they actually created a whole street medicine club at the medical school. So now we have a student leadership team that does a lot of the kind of operations work for our outreach events, which has been supremely helpful. It has allowed me as kind of a leader to really focus more on upper level and kind of service expansion. So another big component, like I mentioned, was developing easier lines of communication between our outreach team and then the providers at each local medical home. We have been able to identify kind of point providers at the two other main clinics, so La Clínica de la Raza and Solano County Clinic. So when we come across someone that we see in a street outreach space who is assigned to one of those clinics, we can reach out to kind of our point providers at those locations, and they can help us navigate that patient through, get them to their appointments, or even sometimes like look up their records. Patients do sign consents with us so that they allow us to do this, but those providers will help us look up their records to clarify, what dose of this medication are they actually on, et cetera. But what I want to spend the rest of the time on is this Kaiser Care Without Walls pilot. So this has been kind of the biggest piece of like Kaiser-based continuation of the National Initiative 7 work. So this we're able to create with the wonderful support of my boss, our residency director, Dr. O'Connell, to continue working with those patients that we see in the street outreach space, or that we were able to identify through the Project Room Key project, who had Kaiser insurance. So just going into this, and I'm just going to check my time here. Okay. So Care Without Walls, again, this is kind of another presentation we used for leadership. I won't go through each of these details. The idea is trying to bring the street outreach model, but into a actual primary care space, with the idea that, these chronic health conditions paired with increased barriers to care actually does feed into this cycle of homelessness, makes it harder for people to get stable housing, and increases rates of emergency room utilization. So our plan was to do much like what we were doing at Project Room Key, and actually go to wherever people happen to call their home. And so that might mean a hotel room, that might mean a tent, it might mean a car. Sometimes we'll meet people. I've met somebody like in the parking lot of a McDonald's, and we go and we meet them and we do a home visit. The difference for these patients is I am their actual primary care provider. And so I am trying to do all the things a normal primary care doctor would do. We've now been able to incorporate our residents into this, so they will come out with me to see these patients. I'm hoping that that can get folded more into their formal education, potentially as they may become primary care providers for some of these patients. We work with a case manager. We have two case managers who work with our Medi-Cal patients through Kaiser. And so I meet with them every other week to go through our patients, and we try to put our heads together to solve what often feels like unsolvable problems, but move forward in that kind of team-based model. So again, as a provider, I'm providing just the normal primary care things, and then always thinking about any medically related social issues. So sometimes as medical providers, we really can help support housing just by signing IHSS or disability paperwork, or even with housing vouchers, certifying that they do need an IHSS worker, so they do need a 2-bedroom apartment rather than one bedroom apartment, for example. These are our kind of target goals, looking in the categories of overall health and well-being for our patients, always having this lens of supporting a transition to stable housing, because that ultimately is the biggest barrier to their health. And then looking more from a cost lens of trying to reduce emergency services and decrease overall healthcare system costs. We're not going to go into each of these risk scores, but really the most important column here is the one on the left, just understanding that as we were looking at our metrics, those are kind of the 3 areas that we were looking. So this was when we kind of did initially when we were approved to do this, we were told we had a 3-month pilot that has since kind of just continued to get expanded again with the support of our leadership. And so in this initial stretch, these were our numbers. You can see the administrative phone calls far outstrip pretty much anything else. And that's basically just the number of times that we would try to call patients, to set up appointments, to outreach to people for whom we got referrals. And then the 61% that attained housing, some of this was a carryover from Project Room Key. We started this a little bit before that ended. And so we chalked those patients as they moved to stable housing. And then some of these were also patients that we were able to help certify that they were disabled. And so they were eligible for a certain disability pool of funding for housing. This graph I only include because I feel like it looks pretty familiar to that Project Room Key graph, where you can see the numbers of patients who actually attended their appointments increased pretty dramatically once so at this time I had my medical assistant join the team, and she started actually calling patients to remind them about appointments, and the show rates increased pretty significantly. Since then, my medical assistant no longer has bandwidth for that, but Toro medical students again kind of save the day. I've had a student who's doing a longitudinal elective with me for a clinical distinction. So she's working with me all year, and she's essentially acting as a program manager, administrative assistant. She's doing all the outreach calls, all the follow-up calls, and the appointment reminders. I think actually I'm running out of time. So our initial kind of takeaway points, for the most part, the patients have been really responsive and very happy with the care. Our biggest issue really is that our numbers are still pretty small. Our cohort is only about 18 patients. And it's harder than you would think to identify and schedule patients who are experiencing homelessness. Not everybody comes in with this blaring on their chart. And so unless people are asking the specific questions, we don't always catch them when they come in. So some of our biggest challenges, as you can expect, frequent cancellation of visits, difficulty contacting patients. A lot of our patients that we have referrals, their phones, they have nowhere to charge them, or they get stolen, or they stop working. And so keeping track of people can be really tricky. We've really tried to work in the mantra of, just try to do as much as you can when the person is sitting in front of you. And then again, just it's the constant balance of having enough patients to prove benefit, and also having enough time to actually care for those patients in the way that we know will make the project work. One piece just from a sustainability lens that, again, is kind of another example of creative pivoting. We, in California, our Medi-Cal system, which is the Medicaid, has gone through a pretty significant expansion, where they are really targeting patients who are high utilizers, who are experiencing homelessness. And there's a whole new breadth of services that we're able to refer these patients to. You're able to get reimbursement for street medicine work, as well as contract and refer to community-based organizations. So this is why our social workers were able to even move into this space with us. And I actually think moving forward, it's going to be how we make this a financially sustainable option. So takeaway, I was thinking about, if I'm looking at moving from the National Initiative 7 to what we're doing now, what have been the most important components to making this continue to work? And I could not have done this had I not had the support from our residency director, Dr. O'Connell. He was part of our National Initiative 7 and was very supportive of that work. And then Care Without Walls really only happened because he decided to give me residency time to make it happen, and has continued to be an advocate when we've spoken with our physicians in chief. And so that has been crucial. This couldn't have happened without that. And then having, I say passionate point person, it feels a little self-serving because that is me. But I think the point is having someone for whom this is their mission. Without that, it won't happen. Utilizing learners, I have learned so much about the capacity of our health profession students, ranging from, all across the definitions of that term. I forgot to mention one of the projects that came out of Project RoomQ is actually one of our Masters of Nursing students who has now created an entire substance abuse case management program that's being wrapped into our nonprofit. But the learners have been absolutely instrumental in making any of this work sustainable. And then finally, pivot. I really feel like looking at this pathway, it's been every time something new happens, just kind of looking to see like, where is the crack, where is the breadcrumb leading me to the next point, and having enough of a framework or kind of a background to be able to jump at those opportunities as they come in. And with that, I will stop.
Well, Emily, this is Kimberly. Thank you so much for a really very inspiring presentation. It's wonderful to see this tremendous work continue and grow. We will pivot now to Victor's part of the presentation. And I know there's been a couple of questions and comments in chat. We'll be sure to address those after Victor has completed his prepared thoughts. Thanks again.
Welcome again to our webinar for today. I'm going to use, let me go back to my starter slide if I can. I'm going to use a lot of the keywords that Dr. Fisher has just given us. So imagine that you're hearing the presentation again with different colors. I don't have financial disclosures to make. I will talk about the AIMC link, and I've talked to internal audiences about this. So let's see. In fact, when we did that, this was a slide in one of those sessions. What are the objectives? Let's talk about how a project has lived from NI7 until now, just like Dr. Fisher did, and let's promote scholarship. Here's the highlight slide, and we'll come back here later. But in terms of where are we likely going to go, let's talk about how you can leverage or expand an existing process so that you can pursue your target. Let's talk about looking at data that is either provided to you or promised you, and the kind of words that we heard Emily use a short while ago, team and passion. Okay, so I'm sitting here in Sayre, Pennsylvania, where we have a habit of choosing metrics for the primary care teams to address. There are goals to be pursued for those metrics, and every year the goal is reset, and we use the academic year format, July to June. So in the season that we were doing NI7, it included the goals that you see here, a diabetes bundle that I'll show you more about, and there are 5 other goals on there. July 2020 was special because it was the first time resident data was going to be counted as part of overall system goals. The previous process was that we were ignoring the resident data. Okay, this is a modified version of what Bloom et al. Published nearly 10 years ago out of a different hospital system, they had 9 pointers for what they did as a diabetes bundle. We broke that down to 6, and I think we've suddenly removed one of those. So 5 is laid out here, and then there are inclusion and exclusion criteria. Okay, we were expected to have huddles in every office, primary care or not. And this was what our design became for huddles, what you see here, and it tells you who the team members were. So yes, we had students coming in because we had a lot of students that were doing their internal medicine rotation here, and they were welcome to do those. And of course, we had all our staff people, and we had a care coordinator actually doing work and giving us prompts to help us with our clinical care to pursue these metrics. And we have a CMO for ambulatory quality who gives us data. Here's a question that came up as we began to look at resident data for the first time. Aren't the residents better than the people that aren't residents? Especially if we have our precepting set up so that every patient is seen physically by both the resident and the attending. Aren't 2 heads always better than 1? It's not what we found. It's still not what we have. And what we were doing, where we included quality pursuits in our expected office huddles, did not close those gaps. Now, of course, this wasn't a randomized controlled trial where we were ignoring one group and trying to feed the other group. We were feeding both groups. So of course, when you start seeing the graphs, you'll see how data seemed to improve in both groups. Okay, we had 6, it's typical for us to have 6 metrics that we're pursuing in the primary care space per year. So that's parsed out. We started with focusing on the diabetes bundle. So that takes care of the top 2 goals, because in that year, the goals were flexed according to what the group's baseline was. So the residents had a lower goal than the non-residents did because they were starting at a lower place. And as the process evolved, we discovered that we had bandwidth to include 4 of the other metrics. So we only left 1 out, but these 7 aims here represent 5 of the 6 metrics that we were working on in primary care. We took a plug and play approach. If you build a platform, people can plug their solo projects into your wider support framework. So one resident had a project to improve diabetes bundle compliance among patients of the residents. Another one was working on improving colorectal cancer screening among resident patients. And a third one was working on improving the rates of completion of transition of care management visits. So these are the visits that people do shortly after they've been discharged from hospital to make sure that their needs are fully integrated and that whatever changes happen in the hospital are fully understood in the primary care space to enhance follow-up. So encouraging the intersection of as many related QI projects as possible. And those 3 residents presented in an I-7 as well as some of these slides that you see here. Welcome to the concept of everyday innovation. Dan Burris brought this up in the annual meeting of the AIAMC in March of 2022. His book is cited here, and you'll see the full reference later. The board that you see here, and if you're able to see further to the right, there's a second board that we added on so that we could have the resident data on. But this board that's nearer to the center of the screen only has the standard huddle work in the bottom, especially on the right-hand corner, talking about where the openings were for same-day access for patients or which staff members were out of the office and so on. But the top of the board has now been engulfed by quality work. So on the left hand, you have aggregate data, and on the right hand, you have a listing of specific providers and how well they're doing in the different metrics, and more to come. Okay, COVID-19 came to us as a shark. That's another keyword I'm bringing in from Dr. Fisher, but We had met our goal for the non-resident providers for diabetes bundle completion as of August of 2020. But when the first wave that came to our system in October did that, we lost all that progress. And even when that wave tapered down by February of 21, we weren't able to get back to where we were. Ultimately, we were able to create this fishbone diagram. So the focus for this slide is bottom middle, where it says pandemic. People didn't want to come in a hospital building, even if they were only going to the lab to do blood work. They were afraid that they would get sick if they did so. And even the labs that were not in the main hospital, but were in other office buildings, weren't appealing to them to go to. Some people did their care virtually rather than come in the office for visits. And it's a different way to say to people, hey, you're due for blood work. Can you walk over and do your blood work if it's a virtual visit, rather than where we are here, where there's a lab within, I don't know, 200 feet walking distance, maybe. Some people could do home lab draws, but not everybody. So that's why those numbers fell down like you saw. Okay. Now, the shark lost its teeth as far as colorectal cancer screening goes, because if you watch this, even though this slide isn't perfectly curated on the x-axis, if you look towards the middle of the slide on the top, September to early October is where we had the biggest gains in our rates of colorectal cancer screening compliance. And that was right before this COVID wave came through. And even though the wave came and raged for about 4 months, we didn't fall back to the baseline for where we were with that. So the moral of the story is sometimes you're looking at metrics on the same screen and you think they're all equal. They really aren't. Here's what we discovered when we closed the year. So of course, NI7 ended in March and we did our presentations, and I've shown you some of the slides that were actual slides from those presentations. And at that point, we were hoping that we would make up the gap that we lost with COVID and our diabetes bundle. Well, we didn't. We hit goal in all of the other metrics. So we had 7 aims on the slide I showed you. We hit 6 of them. But then this diabetes bundle for the non-resident providers, we missed by 0.4 percentage points. So 62 was the goal and we came in at 61.6. However, something happened right before this. And do I need to advance to show you? Well, maybe not. Okay, what happened was on June 23rd, we were at 59%. And we were able to rally in those 8 days or so and get 2.6 percentage points. We didn't hit goal, but we learned something in terms of what we could do later. Okay, so here's the riddle for you. And if you want to blow up the chat with your answer to this, please do that. If you walk into somebody that you've known for several days, could be a week in a clinical scenario, could be somebody you know personally and you're visiting in a hospital or care home or something, and the person appears to be gasping. So you get tempted to run out and ask for help. And you come to this nurse station. Your favorite contact in the nurse station that you talk to every day is distracted on some phone call or something. Somebody else is trying to catch your attention and see if he or she can help you, but you don't know this person, so you don't know what to think. And you're also wondering if you just go back and, hey, you're a doctor anyway, go fix this. So you'll tell me in the chat what you would do. Welcome to the concept of problem skipping. I think we do it all the time. It is in Dan Burrows' book, and he mentioned it to us in March of 22. When I look at this toll plaza here, it seems to me that the leftmost lane is the most direct way to get out of here quickly. I don't like to be stuck in tolls. I want to breeze through and keep going. However, there are red X's preventing me from using that leftmost lane, even though it's the most direct lane. It would be my preferred choice. I can't get through there. And what you see the cars, vehicles in this picture doing is problem skipping. They're going to the lanes that have the green, you can come through here signs. And they're going to pivot and go back to the highway, even though the highway doesn't seem to be where they are. But they're going to gain time here. If I go park my car in front of that leftmost lane there, I'll be there for hours or maybe days. Okay, so we brought problem skipping into how we were working this diabetes bundle for the next year, because that got appointed for the next academic year, 21-22, as a metric. Now, this time our goal was higher. Our goal was about 63.6 or something like this. So because we closed at 61.6 and they like to mark up by so many percent, we had a higher goal, even though we didn't meet the last one. But you can see that we did meet that goal. We got to goal almost in April, and we stayed there till the end of the year. And till now, we're doing well, as I'll show you. Okay, so I like how Amanda's picture shows in first here before the rest of the spine. So now let's focus on this fishbone diagram, top right, where Amanda is standing. And it turns out that part of our process for getting people to complete their lab testing at the time that they should, when should they go do an A1C every 3 to 6 months, or when should they do microalbumin testing at least every year, when should they do cholesterol testing, things like this. That was an outreach that was tasked traditionally to nurses and clinical assistants, still is from a system-wide perspective for us. But in that rally that we did at the end of June of 21 to see if we could hit goal, we invited the patient service specialists. These are the folks that register people as they come into the office. They're the folks that give them their appointments as they leave and so on. So we opened the gate and let the PSSs team up with the nursing staff to pursue this, and it was a big uptick. And come to think of it, we were in a season where we were better staffed on the PSS side of our operation than the nursing side. So this goes to provider staff ratios and things like this. And of course, the nurses bore the brunt, or a part of the brunt, of the pandemic, trying to figure out who needed a call to see if they were taking this med or that, or relaying the questions people had about quarantine or so on. Oh, if I have this illness, should I test? If I was in contact with X person, should I test? Things like that. So we brought our PSS team into this, and they, in fact, Amanda is the leader of this, and you can see her Employee of the Month plaque over there. And here's what we were able to achieve for the end of the 21 to 22 fiscal year, where the provider group that couldn't meet goal the year before was now ranked 4th out of 26 practice teams in that 21 to 22 season. And then you can see what we achieved with the other items. Okay, so there are existing processes you can use to pursue a target that you pick up. If you have data that's provided to you, you can look at it carefully, you can watch for trends, you can test assumptions. And if you're able to find people that are passionate about doing more than what they ordinarily do, people that are up for a challenge for stuff, they are your better helpers than people where you say, oh, but you're the traditional owner of this process. Please stretch a little wider and keep doing this. Well, if they've run out of bandwidth, they need help. Let's see if we can find said help. Okay, so what happened in the last 6 months of 2022? I think we did more with our huddle board. So this is a closer look at what the top right of either of our huddle boards looks like. Each row there, except for 2 towards the bottom, represents a provider, and each column represents a metric that we're tracking. So the diabetes bundle is the first one with the blue, and the colorectal cancer screening is the one with the orange stars, if you see them that way. So the single star represents said provider being at goal for that metric. Double star if they're top 10. And we have more than 150 providers in primary care. So we feel like it's quite nifty if people are in the top 10 of that. So what we began to do here was skip the problem of, oh, we've got one provider, or depending on the season, maybe 2, that are not meeting goals in either one or more metrics. And should we be focusing our efforts on getting them to goal? Or should we normalize excellence? And should we celebrate the people that are leading the world, so to speak? And that's what we were doing with this. Okay, next riddle so that you can blow up the chat even more. If you sustain a project, it will probably give birth to something. You got this theme from Dr. Fisher's talk as well. What is the name of the child that sustain would have? If you were invited to give a name to said child, what would you call it? An English word now. Don't call him Jim, don't call her Taylor. But what English word would you give to the name? I'm going to say spread would be the name. If you sustain something, you can spread it. This is a little story about masking and munching, which the opportunity not to have your mask on in your office all the time was if you were eating. So somebody was munching crackers and people came around and said, oh, what is this we smell in the hallway? What are you eating? And they gathered together and ordered stuff one time. So it seemed like spread occurred. It didn't last long. Maybe external spread doesn't get sustained if you're not the one doing it. And you heard this official story, the things that have evolved from her project, she's the doer of them. So even if people are having opportunities to go talk to wider audiences and saying, oh, here's what we did in our office, that doesn't mean other people are going to pick them up. But what we began to do is what I'll call internal spread. So when the patient satisfaction or patient experience team began to gather steam on our campus and began to provide monthly reports of where people were with their patient satisfaction scores and relative to the goals that they have, we've now set up stars for the people that are meeting goal with that. So that's a newer evolving thing, internal spread. Another part of spread is presentations that you can do to different audiences. So this is a slide from a resident noon conference, but before this, the content was presented to a faculty development session on our campus. And that opens up what we were doing in the internal medicine space to people in surgery and orthopedics and so on and so forth. So that's how you, and this is another slide from that work celebrating the fact that we happen to have a culture that respects and supports quality improvement, and it's something we should keep doing. Okay, what did I learn? Partly starting from the bottom and going up, proximity does better than tradition in terms of reviving dying work. Well, the reason the work is dying is the tradition is no longer matching the current need. So you're trying to look for ways to skip problems. You're looking for open lanes in the toll plaza. And we talk about Swiss cheese, or if you like foosball, here you are, as something that allows medical errors to occur if all the gaps in the cheese line up together. And I think that concept spreads to population health, at least in the ambulatory care space, and perhaps to patient experience as well. Okay, so where do I feel like this can close? I think that when you do a project, you get to determine whether it will be sustained, whether it will spread. If it's something that you can keep going, please do that. Think of the supporting relationships that you had or developed during the process and keep them alive. I feel like spread is a child or a consequence of sustainment. Internal is okay, it doesn't always have to be external. And look out for opportunities where you can present your work and maybe publish things from it. Okay, so here's the data for the end of December of 2022. So on the top line there for the 5 metrics of 6 that we have data for the 22-23 academic year, you can see the provider group on top is healthy. And there are 2 gaps or disparities with the resident groups where a resident is working on each of those projects, and we hope to see growth there over the next season running from January to June of 23. Okay, and then of course, anticipating the next frontier is always a thing. I mean, look how Dr. Fisher was able to be well positioned for how Medi-Cal would be ready to do things that directly complements what she's been doing. So we've now gone into a space where for the first time in years, we want to do some vaccine tracking, and we'll be ready once we get all the information we need. Okay, this tells you what Dan Burris's book was, and if you want to read a blog on it, that is where you can go to the AIMC website. And if you want to blog, Kimberly's ready to hear about it. Thank you.
Oh, Victor and Emily, thank you so very much for these inspiring and really quite impressive presentations. It's so heartening to hear the work of our projects is being hardwired and continued in our institutions. I know we're just about at the top of the hour, but just a couple of things I wanted to mention. Mindy will send out the link for the evaluation as well as CME instructions. A couple of takeaways for me very quickly. With Kaiser, the elective and street medicine and the care without walls, just so very impressive. And Emily, I would ask you, there were a couple questions. The elective, was that a curriculum you grew from scratch, or did you get some other examples? And maybe when Mindy sends out her email, you could reply to all with that answer, as well as the medical record in the street with the homeless. Is that electronic medical record, or is it paper? So those were a couple questions. And what strikes me about Victor's presentation is we always say to align your National Initiative project with your institutions and your C-suite goals. And so clearly you can see at Guthrie, that's what they did. And that's what's really helped sustain the work, because the institution and the C-suite has those same goals and knows the value. And, when we talked about NI7 being teaming, I heard a lot about the students that helped, the RNs, the clinical assistants. Again, just so very impressive. And I'll close today with a shameless plug for our 2023 annual meeting and National Initiative 8 Meeting 4, which will be held March 24 to 26 in Nashville. Dr. Kolade was one of just 5 posters chosen to present in the poster slam. And Dr. Fisher's colleagues at Kaiser Permanente, Northern California, one of which Dr. Tessa Stecker is on this webinar today, they were one of 5 breakout sessions selected. So you've been in really great company today. I know I've enjoyed it, and we really do encourage you to register for those meetings and hope to see you in Nashville. With that, I will again thank Drs. Fisher and Kolade and thank Mindy Apicella for the setup. And we do hope this obviously has been recorded. We hope you share the link with your colleagues and they can watch that recording if they were unable to join us live. So thank you very much. Be well, and we'll be in touch.